You walk into a room and forget why you went there. You search for a word that was in your mouth a moment ago and it simply vanishes. You read something and by the end of the paragraph the beginning is already gone. You have been telling yourself it is simply age, that these things happen, that there is nothing to do about it. I need you to consider something before you accept that explanation. Because for a significant number of people over 60, these symptoms are not the inevitable result of getting older. They are a side effect of something sitting in the medicine cabinet right now. If this channel has ever given you something worth knowing, hit that subscribe button right now, leave a like, and drop a comment below, because that is what keeps this kind of conversation reaching the people who genuinely need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health. Simplified and designed for adults over 60, stay with me through this entire video, because by the end you will know which categories of medication are most associated with accelerated cognitive decline in older adults, what the mechanism is, and exactly what to bring to your next physician appointment to begin addressing it. Let's start with the problem that makes this conversation so important and so rarely had. Most people assume that if a medication was prescribed by a doctor, it has been evaluated for safety at their age. That assumption is only partially correct. Many medications that were studied and approved primarily in middle-aged adults carry different risk profiles in adults over 65, where metabolism slows, the blood-brain barrier becomes more permeable, and multiple medications are frequently taken simultaneously. A landmark study published in JAMA Internal Medicine in 2015 followed more than 3,400 adults aged 65 and older over a 10-year period and found that those taking medications with significant anticholinergic properties at higher cumulative doses had a 54% greater risk of developing dementia compared to those not taking these medications, 54%, from medications that were prescribed as routine, standard treatments. The mechanism behind this finding is a neurotransmitter called acetylcholine. Acetylcholine is the chemical messenger your brain uses to form new memories, maintain alertness, and support clear cognitive function. As the brain ages, it becomes progressively more dependent on adequate acetylcholine activity. A specific class of medications, called anticholinergics, works by blocking acetylcholine receptors. In younger adults with robust cognitive reserve, this blockade is generally manageable. In older adults, whose acetylcholine production has already declined, the same blockade can produce measurable and sometimes lasting cognitive effects. The problem is that anticholinergic properties are not exclusive to psychiatric medications. They are found in sleep aids, bladder control drugs, antihistamines, certain antidepressants, and some gastrointestinal medications, categories of drugs that most patients consider entirely routine and low risk. Let me now walk you through the specific categories of concern and the evidence associated with each. The first category is over-the-counter sleep aids and antihistamines containing diphenhydramine, the active ingredient in many products sold as nighttime or allergy relief formulations. Diphenhydramine is one of the most potent anticholinergic compounds available without a prescription. It crosses the blood-brain barrier easily and directly disrupts hippocampal function, the region most critical for forming and retaining new memories. A study published in the Journal of Geriatric Cognitive Health found that seniors using anticholinergic drugs regularly had a 54% higher risk of developing dementia compared to those who avoided them. Most people taking these products for sleep or seasonal allergies have no idea that the compound they are relying on weekly or nightly is in this category. I had a patient I will call Gerard. He was 66, came in complaining of increasing forgetfulness over the prior 8 months. He described missing appointments, losing words mid-sentence, and feeling what he called a persistent mental slowness he had never experienced before. His only medication change in the past year was beginning a nightly over-the-counter sleep aid. When we reviewed the ingredient list, it contained diphenhydramine. We discussed alternatives, switched to a low-dose melatonin protocol, and within 6 weeks he described his thinking as notably clearer. The second category is bladder control medications, specifically the older class of drugs prescribed for overactive bladder. Oxybutynin is the most widely prescribed of these, and it crosses the blood-brain barrier with particular ease, directly affecting memory regions in the hippocampus. A comprehensive study published in the British Medical Journal in 2019 found that adults over 65 who took strong anticholinergic medications including oxybutynin for more than 1 full year had a 49% higher risk of developing dementia. Nearly 1 in 2 long-term users, the cognitive effects are frequently mistaken for normal aging. Patients report feeling mentally foggy, forgetting appointments, losing track of conversations, and experiencing a general slowing of thought they cannot explain, because no one connects these changes to the bladder medication they have been taking for years. The damage continues without anyone recognizing the source. The third category is proton pump inhibitors, the medications prescribed for acid reflux and gastroesophageal disease, sold under names including omeprazole, pantoprazole, and lansoprazole. These are among the most commonly prescribed drugs in the world, and many patients take them for years because symptoms return when they stop. A study from 2016 published in JAMA Neurology examined over 73,000 people aged 75 and older and found that regular proton pump inhibitor users had a 44% increased risk of developing dementia compared to non-users. The proposed mechanisms include suppression of vitamin B12 absorption, which is essential for myelin integrity and neurological function, and evidence suggesting that these medications may increase amyloid beta accumulation in the brain, the same plaques associated with Alzheimer's disease progression. The fourth category is benzodiazepines, the class of medications prescribed for anxiety and sleep disorders including lorazepam, diazepam, and alprazolam. These medications enhance the activity of the brain's calming chemical GABA, producing sedation and anxiety relief. In the short term they can feel genuinely helpful. Over time the picture changes significantly. A study published in the British Medical Journal in 2022 followed over 8,000 seniors for 6 years and found that those who had used benzodiazepines for more than 3 months had a 51% increased risk of developing Alzheimer's disease. The risk was higher still for longer-acting formulations that remain in the body longer and accumulate in fatty tissues including brain tissue. Seniors taking benzodiazepines regularly often describe feeling as though they are moving through a persistent fog, feeling disconnected from their surroundings, and not quite feeling like themselves when they try to stop. The withdrawal symptoms including rebound anxiety and severe insomnia make the medication feel essential, even though it has become a primary source of the problem. The fifth category and the most important one on this list is not a single medication, it is the cumulative effect of taking multiple medications with anticholinergic properties simultaneously, a situation called anticholinergic polypharmacy. A 2022 analysis published in Age and Aging tracked over 280,000 older adults and found that those with the highest cumulative anticholinergic burden had a 120% increased risk of developing dementia within 10 years, more than double the baseline risk, from medications that are frequently considered routine and benign when viewed in isolation. What makes this so serious is that no single prescription triggers an alarm. The sleep aid seems harmless. The bladder medication seems unrelated to cognition. The antihistamine is over the counter, but when 3 or 4 of these medications are taken together daily, the combined blockade of acetylcholine receptors in the aging brain is not additive, it is compounding. Neurons that are chronically deprived of adequate acetylcholine signaling begin to atrophy, synaptic connections shrink, and the resulting cognitive picture can be clinically indistinguishable from early Alzheimer's disease on standard testing. I need to say something now with complete clarity and without any softening: do not stop any prescription medication based on what you have heard in this video. Do not reduce doses, do not switch medications on your own. The risks of abrupt discontinuation for several of these drug classes, including benzodiazepines and some antidepressants, include seizures, cardiac events, and severe psychological crisis. These are not theoretical risks, they are documented and serious. What this video gives you is the information and the specific language to bring to your physician so that together you can make informed decisions about your medication profile. That conversation is the entire point. Now, what does the evidence support as a constructive path forward? A thorough medication review focused specifically on anticholinergic burden is the most important first step. There are standardized tools, including the Anticholinergic Cognitive Burden Scale, that allow physicians and pharmacists to calculate the cumulative anticholinergic load of a patient's complete medication list. For bladder control, newer medications such as mirabegron work through a completely different mechanism and have shown significantly less impact on cognitive function. For sleep, low-dose melatonin and cognitive behavioral therapy for insomnia have demonstrated efficacy in clinical trials and carry none of the anticholinergic burden of diphenhydramine-based sleep aids. For anxiety, buspirone, and structured psychological therapies have shown benefit without the cumulative cognitive risk of long-term benzodiazepine use. For acid reflux managed by proton pump inhibitors, H2 blockers such as famotidine are less likely to interfere with B12 absorption and cognitive function, and gradual tapering under physician guidance can reduce or eliminate the need for daily acid suppression in many patients. I want to tell you about a patient I will call Dorothy. She was 71, came in because her family had noticed significant personality and memory changes over the previous 18 months. They were preparing for a dementia diagnosis. When I reviewed her complete medication list, she was taking diphenhydramine nightly for sleep, oxybutynin for bladder control, and a proton pump inhibitor she had been on for 6 years. Her cumulative anticholinergic burden score was in the high-risk range. We worked with her physicians over 4 months to gradually taper the diphenhydramine, transition her bladder medication to mirabegron, and begin a supervised reduction of the proton pump inhibitor. Within 3 months her family described her as meaningfully more present. Her memory testing improved by a clinically significant margin at her 6-month follow-up. She told me she felt like herself again for the first time in over a year. Drug-induced cognitive impairment, when identified early enough, is frequently reversible. That is perhaps the most important thing I will say in this entire video. Here is exactly what to do. Step 1. Write out every medication you take, including over-the-counter products, sleep aids, antihistamines, and supplements, every single one. Step 2. Bring that complete list to your next physician or pharmacist appointment and ask them to calculate your cumulative anticholinergic burden using a validated scoring tool. Step 3. Ask your physician specifically whether any medication on your list has been associated with cognitive effects in adults over 65, and whether it appears on the Beers criteria, which is the American Geriatric Society list of potentially inappropriate medications for older adults. Step 4. Ask whether any of the medications you are taking for sleep, bladder control, or reflux could be reduced, tapered, or replaced with alternatives that carry less anticholinergic burden, and ask what a supervised tapering timeline would look like if appropriate. Step 5. Ask your physician to check your vitamin B12 level and your vitamin D level, as both are commonly depleted by medications in these categories and both play documented roles in cognitive health and neurological function. One important clarification before we close: not every person taking these medications will develop cognitive impairment. The risk described in the research studies represents population-level probability, not individual certainty. Many people take proton pump inhibitors, antihistamines, or bladder medications without experiencing measurable cognitive effects. Genetics, baseline cognitive reserve, duration of use, dose, and the number of simultaneous anticholinergic medications all influence individual risk. This video is not intended to create alarm about medications that are genuinely necessary for your health. Some medications on this list are essential for specific conditions and cannot safely be discontinued. The goal is not to eliminate medication. The goal is to ensure that every medication you take is still necessary, still the best option available for your situation, and that its risks have been evaluated in the context of your current age and complete medication profile. That is a conversation you have every right to have, and you now have the specific language to begin it. Your brain is not simply aging. In many cases it is responding to what it has been given. If this video gave you something useful, hit the like button right now. Leave a comment telling me whether you plan to bring a complete medication list to your next appointment, and share this with someone you care about who has been told their memory changes are simply part of getting older. That explanation deserves a second look. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.